The sacrum occupies a biomechanical position of singular importance within the musculoskeletal system. Its dual roles as a static loading distributing structure and as a dynamic kinematic participant in lumbopelvic motion demand a thorough appreciation of the interplay between osseous morphology, ligamentous architecture, and neuromuscular control. Clinically, the assessment of sacral biomechanics necessitates an integrated approach, incorporating evaluation of lumbopelvic alignment, sacroiliac joint mobility, and provocation testing, myofascial force closure capacity, and the influence of systemic factors such as hormonal status and bone mineral density. Advances in three-dimensional motion analysis, finite element modeling, and in vivo pressure measurement continue to refine our understanding of sacral mechanics with direct translational implications for the management of pelvic girdle pain and the rehabilitation of the elite female athlete. Sacrum is a large triangular osseous structure formed through the progressive synostosis of five sacral vertebral segments designated S1 through S5, a process that commences during early adolescence and is typically complete by the third decade of life. Structurally, the sacrum articulates superiorly with the fifth lumbar vertebrae at the lumbosacral junction, inferiorly with the coccyx at the sacrococcygeal joint, and bilaterally with the iliac bones of the os coccyx via the sacroiliac joints, forming the posterior arc of the pelvic ring. The anterior surface of the sacrum is concave and characterized by four pairs of anterior sacral foramina through which the ventral rami of the sacral spinal nerves course. The posterior surface is convex, featuring the median sacral crest, the fused remnant of the sacral spinous processes, and the posterior sacral foramina transmitting the dorsal rami. The sacral promontory, the anterior-superior projection of S1, is a critical anatomical landmark in both obstetric measurement and biomechanical analysis, as it represents the apex of the lumbosacral angle. The load transmission and force distribution in an erect bipedal posture, gravitational and axial compressive forces generated by the superincumbent body weight converge at the lumbosacral junction and are transmitted inferiorly through the sacrum. The sacrum functions as the structural keystone of the pelvic arch, a concept analogous to the central voussoir in a Roman arch, redistributing these vertical compressive forces laterally through the sacroiliac joints into the ilia and ultimately into the femoral heads via the acetobula. This mechanism of load dispersal is referred to biomechanically as force closure and is distinct from form closure, the latter being the passive stabilization afforded by the interlocking joint surfaces and the surrounding ligamentous architecture independent of muscular activity. The resultant force vector acting on the sacrum during the static stance produces a net tendency for anterior rotation or nutation at the sacroiliac joints, a tendency counteracted by the tension developed within the posterior sacroiliac ligament complex, particularly the interosseous and long posterior sacroiliac ligaments, as well as the sacrotuberous and sacrospinous ligaments. Kinematics, nutation, and counter-nutation. The sacroiliac joint, despite its historically contested status as either a true synovial articulation or a fibrocartilaginous amphiorthosis, permits limited but clinically significant motion. Contemporary three-dimensional kinematic analysis employing intracortical pin fixation methodologies have quantified sacroiliac motion as approximately 1 to 4 degrees of rotation and 1 to 2 millimeters of translation under physiological loading conditions. Nutation is defined as the anterior rotation of the sacral base in the sagittal plane relative to the ilium. That is, the sacral promontory displaces antero-inferiorly while the sacral apex and coccyx displace posteriorly. Nutation is associated with increased tension in the posterior sacroiliac ligaments, sacrotuberous ligament, and sacral attachment of the thoracolumbar fascia. This configuration increases joint congruence and enhances the pelvic stability, a mechanism exploited during the loading phase of gait and in preparation for axial loading activities. Counter-nutation is a converse movement, a posterior rotation of the sacral base relative to the ilium, resulting in a posterior superior displacement of the sacral promontory and anterior displacement of the sacral plexus. This configuration reduces posterior ligamentous tension and is associated with relative joint laxity. The counter-nutation is observed during posterior pelvic tilt, the crook-lying position, and in the peripartum period under the influence of relaxin-mediated ligamentous hyperlaxity. It is imperative to recognize that nutation and counter-nutation are not isolated unilateral events in dynamic function. Rather, they occur as components of a coupled triplanar motion within the lumbopelvic complex. Iliac joint mechanics, form and force closure. Sacroiliac joint represents one of the most mechanically complex articulations in the axial skeleton. The articular surface is characterized by reciprocal auricular facets with age-related fibrocartilaginous proliferation, ridging and interlocking irregularities provide form closure, passive mechanical stability through geometric congruence independent of active muscular contribution. However, form closure alone is insufficient to maintain joint integrity under the dynamic loading demands of upright locomotion. Force closure, the active compression of the joint surfaces, achieved through the co-activation of muscles whose line of action across the sacroiliac joint is therefore an essential stabilizing mechanism. The muscles primarily implicated in sacroiliac force closure constitute a functional sling system. These include gluteus maximus acting in concert with the contralateral latissimus dorsi via the posterior oblique myofascial sling, the biceps femoris through its sacrotuberous ligament attachment, and critically the deep local stabilizers of the lumbopelvic region, namely the transversus abdominis, the multifidus, and the levator ani component of the pelvic floor musculature. The concept of self-bracing, as articulated in the integrated model of Vlaming and Stoeckart, describes a synergistic interaction between myofascial tension and ligamentous pre-stress that optimizes sacroiliac joint congruence. Disruption of this integrated mechanism, whether through muscular atrophy, neuromuscular inhibition secondary to pain, or ligamentous insufficiency, precipitates aberrant joint mechanics and is recognized etiological factor in sacroiliac joint dysfunction syndrome. Sacral biomechanics during gait. During the gait cycle, the sacrum undergoes a complex coupled rotational movements that are intrinsically linked to contralateral pelvic and lumbar motion. This coordinated pattern described within the conceptual framework of the lumbopelvic rhythm is fundamental to efficient bipedal locomotion. The piriformis muscle, given its direct sacral origin and its role as a primary external rotator of the hip, exerts a significant stabilizing moment on the sacroiliac joint during single leg stance. Hypertrophy or contracture of this muscle can alter sacral positioning and contribute to sciatic nerve irritation, the so-called piriformis syndrome, which must be distinguished from L4, L5 radiculopathy in clinical assessment. The stance phase of the right lower extremity. The right ilium undergoes posterior rotation related to the sacrum, producing a relative right on right sacral torsion, while simultaneously the left ilium undergoes anterior rotation. Concurrently, the lumbar spine demonstrates a contralateral rotation, creating the characteristic counter-rotational pattern between the thorax and pelvis that minimizes an angular momentum and metabolic cost. In the peripartum context, the combined effect of relaxin-induced ligamentous laxity and the anterior displacement of the center of mass during the pregnancy produces compensatory posterior pelvic tilt and increased lumbar lordosis, fundamentally altering sacral kinematics and substantially elevating the sacroiliac joint loading. The role of the pelvic floor and the lumbopelvic stabilization rehabilitation in restoring the functional force closure should be the most important treatment goal. Sacral structures, while less common than in the appendicular skeleton, are an under-recognized entity in high-performance female athletes and in osteoporotic populations. The characteristic edge-shaped or Hondo-sign pattern on magnetic resonance imaging reflects the biomechanically susceptible zones of the sacral ala, regions subject to peak cyclic loading during repetitive impact activities. Advances in three-dimensional motion analysis, finite element modeling, and in vivo pressure measurement continue to refine our understanding of sacral mechanics with direct translational implications for the management of pelvic girdle pain and the rehabilitation of the elite female athletes.